Oh, maybe someone. Good morning. I'm Dominique Costco. I'm the program director for the Internal Medicine Residency Program, and welcome to our final episode of Senior Grand Rounds. So before we get started with this morning's two speakers, I really want to extend a congratulations to all of our seniors who participated in Senior Grand Rounds this year. They've been outstanding talks. I've been very impressed, and I've learned a lot from each of the speakers who have presented. So I encourage you, if you're working with one of our residents who presented, or you see them in the hospital, to extend your congratulations. It's a lot of hard work to pull this off in a short period of time when they get the invitation from our chief residents. So I wanted to say congratulations to all. So this morning, I have the pleasure of introducing our first speaker, Dr. Vijay Kannuthurai. Did his undergrad work at Mississippi State, where he majored in biochemistry. He then attended the University of Mississippi Medical Center, where he graduated AOA. He joined our residency program in the primary care track, and he has plans to pursue fellowship in rheumatology. This morning, he's going to be speaking about the primary care of patients with rheumatoid arthritis, recognizing and reducing cardiovascular risk. This is a topic that is near and dear to his heart because it combines two of his favorite topics, primary care and rheumatology, and recognizing how to prevent future cardiovascular risk. So welcome.
Thank you, Dr. Costco, for that introduction. So we'll get started. So first, I have no financial disclosures. And for our learning objective today, first we'll discuss the mechanisms in which rheumatoid arthritis can affect cardiovascular health and increase the risk of cardiovascular disease for patients. We'll talk about some European guidelines and recommendations regarding CVD, or risk assessment and management in patients with RA. We'll talk about some recommendations that I would offer to primary care physicians that are treating patients with RA or other types of inflammatory joint disease. And then we'll apply all of these principles that we discussed to a case. We'll actually start with that case. Ooh. So imagine you're in clinic and you see this patient, a 58-year-old African-American female with a history of rheumatoid arthritis here at your clinic to establish care. So this patient tells you that she's followed pretty routinely with a rheumatologist since her diagnosis of RA about 8 years ago, but she's never consistently seen a primary care provider, but now she's interested in beginning health maintenance and cancer screening and things like that. She mentions that her disease is fairly stable. She's been on a stable dose of methotrexate. She takes prednisone 5 milligrams every day. She takes meloxicam as well. Unfortunately, she's got a lot of joint pain, and so she tells you she doesn't really exercise that much, but she doesn't have a history of diabetes. She doesn't smoke or use alcohol. And you can see there her cholesterol is okay. Her blood pressure is a little borderline. So let's say you're in your clinic or you're a resident, you're staffing this with your attending, like Dr. Costco. So what additional recommendations would you have for this patient other than her age-appropriate vaccinations and screening? Hopefully at the end of this presentation, you'll have more of an idea of what you could talk to this patient about, unless you're like Jesse here and you're half asleep during the whole thing. So as we all know, rheumatoid arthritis is a chronic autoimmune and inflammatory disease that affects up to 1.3 million Americans and 1% of the worldwide population. Some hallmarks of the disease are the inflammation and joint destruction, and that can lead to a loss of physical function and obviously complicates your ability to carry out your daily tasks in maintaining employment. So the life expectancy of patients with RA can actually be decreased by 10 and sometimes up to 15 years compared to patients without RA. And studies have shown that there's this increased mortality in patients once they're diagnosed with RA. And so the things that contribute to this increase in mortality involve a lot of the comorbidities that are associated with RA, and there's some that we all think of, like depression and OA, and some of the more rare things like pulmonary fibrosis and GN and vasculitis. But a large component of that increase in mortality is actually this cardiovascular disease risk, namely ischemic heart disease, heart failure, and stroke. There's actually been a lot of research in the last 10 or 15 years in terms of how serious or how significant this risk of cardiovascular disease is. So when I was looking into this, I found a lot of great info from the series of studies using this cohort of patients in Rochester, Minnesota from the Mayo Clinic. And it sort of starts off with this one where they looked at cardiovascular death in patients with RA. And what they showed was that the traditional risk factors that we all think of, history of heart disease, smoking, high blood pressure, diabetes, these are all significant risk factors for cardiovascular death in patients with RA. But they also found that patients with RA that had at least 3 ESR values above 60 actually had a much higher risk of cardiovascular death. So this is sort of suggesting that inflammation plays a large role in cardiovascular disease in patients with RA. So further studies have shown that the incidence of ischemic heart disease has actually increased in patients with RA. And this is actually can precede their clinical diagnosis by a rheumatologist using the established diagnostic criteria for RA. So at the time of their diagnosis of RA, patients have a higher odds ratio of already being hospitalized for an MI or even having a silent MI. And both of these were associated with an increased risk of sudden cardiac death. And then they followed these patients from the time of their diagnosis of their RA, and they found that they had higher incidence of silent MIs, actually had less angina, and fortunately both of these factors contributed to higher incidence of sudden cardiac death. They also found for these patients that following an MI, they did worse compared to patients without rheumatoid arthritis. So these patients have higher mortality, they have higher recurrent ischemia, and this is despite their cardiovascular risk factors, the characteristics of their MI, their treatment with either reperfusion or medications being similar to patients without RA. And this is just a figure that sort of highlights that as well, that patients with RA have higher mortality after an MI compared to patients without RA, despite similar treatments. So this can also, or this increase in cardiovascular disease is also seen when you talk about heart failure in rheumatoid arthritis. So compared to patients without RA, patients with rheumatoid arthritis actually have twice the risk of developing heart failure. And they've looked at it, and this excess risk is not really explained by any increase in traditional cardiovascular risk factors in these patients or any increase in clinical ischemia. And the studies that they've seen have shown that this increase in heart failure is actually more significant in women compared to men, although with RA, although they both have higher chances of developing heart failure. And one thing that I found that was interesting is that heart failure can present sort of atypically in patients with RA. And so these patients, like we discussed, are more often female, but they were actually less likely to be obese or to have high blood pressure or to have had ischemic heart disease. These patients have fewer symptoms of heart failure, fewer physical exam signs, and so they're actually less likely to undergo echocardiography. But whenever they did, studies have shown that patients with RA tend to present more with preserved ejection fraction compared to patients without RA. And unfortunately, they also have a higher mortality in the first 12 months after diagnosis of heart failure compared to patients without rheumatoid arthritis. And I think the study that stuck out to me the most when I was researching all of this was this study from a different group than the Mayo Clinic group. So they looked at patients with rheumatoid arthritis, and they looked at patients without rheumatoid arthritis, but that had type 2 diabetes of similar duration, and they found that their risk of preclinical atherosclerosis and cardiovascular disease was actually similar. And they have this graph that they included in their study, which the color scheme is not great, but the top line is the black line signifying patients that don't have diabetes and don't have RA. The line under that is the gray line under that are patients with diabetes, and then the line under that, which they're calling dark gray, are patients with rheumatoid arthritis but that don't have diabetes. And this was looking at their probability of having no cardiovascular events over 3 years. And you see that the patients with diabetes and the patients with rheumatoid arthritis had a pretty similar risk of having a cardiovascular event over the 3 years that they followed them. And like we discussed previously, similar to diabetes, these patients they report less angina, they have higher incidence of silent MIs, and unfortunately more sudden cardiac death. So why is this important? Well, first off, there are a few guidelines on actually how to manage cardiovascular risk in patients with RA. And there's actually I find a large gap in care for these patients. So there have been several surveys and they've shown that only half of patients with RA are even aware of this increase in cardiovascular disease risk, and that only between 32 and 50% of primary care providers actually know that there's an increase in cardiovascular disease in patients with RA. And furthermore, most rheumatologists don't want to treat hypertension, whether that's because they feel like they don't want to step on PCP's toes, or they feel like maybe it's outside of their scope of practice, or they don't feel like they're the person that should be managing someone with systolic blood pressures of 160s and 170s and following them in clinic. So whether it's because providers are not aware of this risk, or patients, or they don't feel comfortable treating it, there is a large gap in treatment for patients with RA in terms of managing their cardiovascular disease risk. So why do these patients have increased cardiovascular disease? Well, in addition to the traditional risk factors, there are a lot of RA-specific factors. And I think a lot of these are probably outside of the scope of this talk, but there's a few that we'll touch on, including insulin resistance and NSAIDs and steroids and smoking. But one of the big ones I wanted to highlight was inflammation in general, as we discussed. And I really like how this figure puts it. So basically, the pro-inflammatory cytokines that we all think about being associated with RA, the immune complexes can affect the blood vessels by increasing arterial wall inflammation, increasing endothelial dysfunction. They cause more stiffness and atherosclerosis, and they can actually destabilize coronary plaques, all of these leading to increase in cardiovascular disease risk. And studies have shown that decreasing the inflammatory burden or treating the RA does translate into a lower cardiovascular disease risk. And I think it's important to know that while the exact role of these autoantibodies is unknown, it's been shown that being a rheumatoid factor positive is actually associated with the increase in cardiovascular mortality, and being anti-CCP positive is also associated with higher subclinical atherosclerosis and development of ischemic heart disease. And then these patients also have more insulin resistance. So these pro-inflammatory cytokines, TNF-alpha, affect insulin sensitivity, and these patients have more incidence of metabolic syndrome, but treating their disease has been shown to reduce this or to improve this insulin sensitivity. And NSAIDs and steroids are a tricky topic. I think for a lot of patients, these are pretty invaluable in terms of treating their inflammation and their pain and allowing them to be functional. But of course, both of these drugs have been associated with an increased risk in cardiovascular disease. And so it's probably more of a conversation between the patient and their rheumatologist, but whenever possible, long-term use of these medications should be discouraged. So really the only guidelines that I've seen published for this come from the European League Against Rheumatism. And so they have these 10 recommendations for how to manage or cardiovascular disease risk in patients with rheumatoid arthritis. I think there's some that are pretty important for the primary care provider to know. So we'll touch on those in the next few slides. First off being hyperlipidemia. So lipids sort of present a little paradoxically in patients with poorly controlled RA, or maybe before they're diagnosed with RA when they have high levels of inflammation. They actually have lower levels of total cholesterol. And so for this reason, they recommend using the total cholesterol to HDL ratio, which they suggest is a better risk predictor of cardiovascular disease than individual lipid components. And they also mention that because of this, because of how it's affected in high inflammatory states, that lipids should ideally be assessed whenever patients have stable disease or their disease is in remission. And this was a good study that sort of showed that paradoxical relationship. And so you see here with low levels of ESR, with low levels of inflammation, it sort of behaves like you would expect. This dashed line, which are patients with a total cholesterol HDL ratio of 6, have a higher hazard ratio for cardiovascular disease. But as this ESR increases and their inflammation increases, you see that relationship becomes inverse, and patients with a lower total cholesterol to HDL ratio actually have higher risk for cardiovascular disease. The question is, when do we start statin? And we all use these Framingham risk scores or the ASCVD risk calculators to determine when we should start patients on statins. But these calculators don't take into account specific RA factors that we talked about in that figure, especially their disease activity and their inflammation and if they're on steroids. And studies have shown that the Framingham risk score underpredicts the cardiovascular risk for patients with RA. I think that's it's been shown. So with this study, if you observe that the dashed line is actually the predicted 10-year cardiovascular disease risk based on using the Framingham risk score, and the solid line is their actual observed risk. You see that at the bottom here in patients that were seronegative, that what you'd expect using the Framingham risk score and what they actually saw was pretty similar for seronegative women and men. But when they were seropositive, you see that the Framingham risk score really underpredicted their 10-year risk of cardiovascular disease. And so to more accurately predict their cardiovascular risk, the European League in 2017 recommended that you use this 1.5 multiplication factor to whatever risk score that you use to predict their cardiovascular disease risk. And this is actually, they want you to use this risk score without restriction. So in 2009, their recommendations, the patient had to have certain RA-specific criteria, such as they had to have disease for over 10 years, or they had to be seropositive, or they had to have certain extra articular manifestations. But now with more evidence that this cardiovascular disease risk is increased even in patients with early RA, they now recommend you use this multiplication factor for everyone with RA. And statins sort of have a dual effect. So in addition to decreasing your total cholesterol, they also have been shown to have a pretty significant anti-inflammatory effect. And so there have been a few trials on this, the TRACE trial and the TARA trial, which have shown that statins have a lipid controlling and an anti-inflammatory effect. And actually, after discontinuation of statins in this TARA trial, these patients actually had an increase in all-cause and cardiovascular mortality in the first month, probably due to the decrease in the anti-inflammatory effect of statins. In further studies that have looked at statins and their anti-inflammatory effects, have also shown that they reduce arterial stiffness, that they decrease levels of pro-atherogenic lipids and markers of oxidative stress, and they also improve endothelial function and decrease CRP and TNF-alpha. So of course, if you're seeing these patients in your clinic, you don't want to forget about their traditional risk factors, things like hypertension and whether they smoke or if they have high blood sugar. But I think for patients that are high risk, patients that are seropositive or they have aggressive disease or they have high inflammatory markers when you see them in clinic, you could consider specialized testing with ambulatory blood pressure monitoring, with stress tests or echoes and things like that. And physical activity is something else that you want to talk to your patients about. As you can imagine, patients with RA tend to be, or physical inactivity is pretty common in this patient population due to pain and disability. So when possible, tailored approaches for these patients depending on their level of disability, such as anaerobic or water aerobics would be advisable. And exercise has been shown to reduce inflammation and is associated with lower levels of CRP and an improved microvascular and macrovascular function, and so always advisable for patients with RA to exercise. And lastly, tobacco use. So smoking is a strong independent risk factor for RA. Yet lots of RA patients still smoke. And tobacco use has been linked both with progression of disease and actually reduced medication efficacy. And so whenever you see these patients in your clinic, it's really important to early and aggressively talk to them about smoking cessation and referring them for counseling or starting medications or whatever you can do to prevent them from smoking. So as we wrap up, we'll circle back to our case. So we have this patient that we see in clinic, and if you've just taken her data and calculated her ASCVD risk score, you've gotten 5.2%, which puts her in a borderline category. But whenever you use this multiplier that EULAR recommends, this increases to 7.8 or more in the intermediate risk category. And on top of that, you know that she's physically inactive, that her blood pressure is kind of high, that she's on prednisone and steroids or daily. And what else could you talk to this patient about? Certainly, you'd want to discuss her increased risk of cardiovascular disease and making sure this patient is aware of that risk. You could certainly talk about starting a blood pressure medication, a statin, maybe finding a exercise program that's more suitable for her and her level of ability. But then also you could talk with her and even her rheumatologist about her medications and whether she actually needs to be on prednisone and steroids daily or NSAIDs daily, and whether she warrants any further screening with something like an echo or a stress test or something like that. So in summary, patients with RA, studies have shown that they carry the same risk of cardiovascular disease as patients with diabetes of similar duration, that this cardiovascular disease risk actually precedes their diagnosis of RA. These patients have increased incidence of both ischemic heart disease and heart failure, and they actually have worse outcomes from both of these conditions in patients without RA. Remember that whenever you're seeing these patients and calculating a cardiac disease risk score for them, to use this multiplier. It's 1.5 multiplier that UR recommends. And then don't forget to talk to them about traditional risk factors, their high blood pressure, their high glucose levels, physical inactivity, and smoking. And then when possible, discourage them from using NSAIDs or steroids for a long period of time. So if we're doing questions at the end. Okay, thank you. Thanks, everybody. I want to thank Dr. Lisa Zicker for helping me come up with this topic in the first place. Obviously, Dr. Costco for her supports, and all the chiefs, especially Ava, for guiding us through this process. And of course, all my fellow interns and residents for their support and their kind words over the last couple of years. Thank you.
Good morning. I'm Megan Wren. I'm one of the Associate Program Directors, and I'm really pleased to introduce our next speaker, Dr. Ellie Christensen, especially because I've known Ellie for many years. So Dr. Christensen graduated from Fordham University with a degree in chemistry and many honors on her CV. She then attended Washington University for medical school, where she continued to excel in every aspect. She demonstrated a special aptitude for teaching and was selected as a teaching assistant for the cardiovascular diseases course and as clinical mentor for the first year practice of medicine course, as well as volunteering her time and community service teaching. She was elected to AOA. We were pleased to recruit her here to Barnes Jewish Hospital for residency. Here with us, she provides exceptional and compassionate patient care, teaches in a supportive manner, and does cardiology research. Next year, she will serve as the VA Chief Resident of Quality and Patient Safety. Her topic today is very timely on the future of telehealth. Thank you, Dr. Christensen.
Thank you, Dr. Wren, for that introduction. So today, as Dr. Wren mentioned, I'm going to be talking about telehealth and how it potentially can be used as a resource moving forward post this pandemic. I chose to talk about this because very quickly with the peak of this pandemic in St. Louis, our resident primary care clinic was very quickly able to transition to almost fully telehealth visits. And after performing a number of these visits with my own patients, I realized that this was a very valuable resource that we had not really been utilizing previously. I have no financial disclosures today. First, I'm going to touch on the foundations of telehealth, what it is, kind of where it started, and what we've known about it previously. Next, I'm going to touch on the revolution of telehealth and what changed during the COVID-19 pandemic. And finally, I'm going to talk about the role of telehealth potentially moving forward and what issues potentially will arise with that. But first, what is telehealth? The WHO defines telehealth as the delivery of healthcare services where distance is a critical factor by healthcare professionals using information and communication technologies for the exchange of diagnosis, treatment, and prevention of disease. And this is all in the interest of advancing the health of individuals and their communities. Now, this is a very broad definition, and it encompasses a wide range and types of telehealth. And
I liked this kind of graphic here because it breaks down telehealth into 3 main types based on kind of who is interacting with who. First is clinician to clinician, where providers are communicating amongst each other over video, email, or some combination of the above. This is frequently used in dermatology, radiology, and EICU care, where providers at different geographical sites are communicating for patient care. Second is clinician to patient. This is where providers are providing care to their patients over video, phone, email, or some other internet forum. And this is frequently used for care of chronic conditions, medication management, counseling, and other outpatient follow-up care. And then finally, patients interacting with mobile health technology is also another form of telehealth. And this is patients interacting with wearable monitors such as Fitbits and Apple Watches, using smartphones, other apps, and videos. This is patients kind of taking their own initiative to advance their own health education, monitoring their physical activity, monitoring their diet, and medication adherence. Today, I'm going to be focusing on this clinician to patient telehealth for most of this talk. So telehealth has been in existence for over 100 years. This is the cover of Science and Invention magazine from 1925, which depicts a doctor diagnosing a patient over radio, and then also envisioning a device that would allow for video examination of a patient over distance. So kind of looking forward into the future and guessing where we are today. And even prior to this, telegraph was used during the Civil War to transmit X-ray images of casualties of war for their proper treatment. And in the 1870s, there was an article published in Lancet that talked about using telephone as a way of reducing unnecessary office visits. And then moving forward to the 1900s, Einthoven, the inventor of the EKG, published a paper on the use of telecardiogram, which uses the electrodes from an EKG and is transmitting those over telephone wires to another faraway site. The 1960s is around the first time where television and video was used in the kind of means that we use it today. It was first really used in Nebraska with communication between their psychiatric institute and their state hospital to provide psychiatric care to the state hospital where they did not have any on-site psychiatrists. And then in the 1970s, NASA was also a big force in moving along telehealth as they began applying space technology to healthcare delivery to remote Indian reservations in Arizona. And they also used mobile physiologic monitoring with their Mercury space program. And then moving forward to the 1990s and 2000s is more where we think of telehealth as it is today, with video conferencing and internet use and phone visits. There are a number of telehealth systems in practice, and one of the ones that I really like is set up in Alaska, and it's been in place since about 1999. As Alaska has a landmass that's 2.5 the size of Texas, but only a population of 800,000 people, obviously it's very geographically spread out. And a number of these small villages don't even have a nurse practitioner in their community, let alone a hospital or a doctor. Therefore, this Alaska Native Tribal Health Consortium, beginning in 1999, set up a telehealth system where they have community aides in place that are kind of function and are trained as similar to EMTs, where they're able to form kind of minor procedures and are able to get vital signs and do an exam. And then they set up patients with telehealth to communicate with primary care providers and specialists, allowing them access to care that they would not have had otherwise. Changing gears a little bit, even prior to COVID, there have been a number of studies that have been published in regards to telehealth, and most of these have been published with chronic disease. And pretty consistently, they've shown that patient outcomes with chronic disease have improved with telehealth interventions. And I have some examples here. There's a number of randomized control trials in the heart failure literature that have shown that consistent telehealth interventions have led to reduction in hospitalizations and decreased cost of care. Similarly, in hypertension, telehealth has shown to lead to improved blood pressure control. In cirrhosis, where hepatologists are a limited resource and patients in rural communities likely don't have access to them, telehealth allows them access to those specialists. And then in skin cancer, telehealth apps and similar devices have shown to lead to increased screening rates. Most of the robust data for telehealth in chronic disease comes from type 2 diabetes. Again, there have been a number of trials published with type 2 diabetes showing improved glucose control in telehealth, and this is one such trial. In this study, they looked at 90 Medicaid and uninsured patients and randomized them to a regular telehealth intervention versus control, which was just kind of regular episodic office visits. And they were able to find that at a 6-month mark, the telehealth group had a significantly reduced A1C compared to the control group. The telehealth group's A1C improved by about 1.5% compared to only about 0.5% in the control group. And that's shown in the graph on the left. In the graph on the right, it just shows that the telehealth group similarly had a higher likelihood of maintained A1C at this 6-month time period compared to the control group. Now, even beyond improvement in patient outcomes, there are a number of other benefits to telehealth over traditional office-based care. One is that we are able to reach disadvantaged and rural populations who otherwise would not have access to care. Second is that we are able to observe patients in their home environment and get a sense of where these patients are living and what they're interacting with on a daily basis. For patients, it also has decreased wait times and less commuting. And then as providers, we are able to more frequently monitor our patients because they don't have to come into the clinic. This improved access to care with telehealth has been associated in a number of trials as well with increased patient satisfaction. And in one systematic review, they found that these were the most often cited factors by patients. First was that it's easy for them to use, it's low cost, they have improved communication with their healthcare provider, they have decreased travel time and shorter wait time. However, despite these potential benefits of telehealth and the high patient satisfaction that we know exists, its use up until now has been quite limited. And that's demonstrated by this survey. In 2019, PwC surveyed CEOs of a number of large US healthcare systems, and 38% of these CEOs reported having no digital component in their overall strategic healthcare plan. And 94% of these respondents pointed to data protection, privacy regulations, and HIPAA rules as their main factors limiting further implementation of these digital strategies. So far, the growth of telemedicine has been quite slow, and it's been limited by a number of factors. The first of these is that the policies surrounding telehealth have been very strict in regards to its licensure, credentialing, and malpractice. Second, although these digital technologies have been in existence for decades, they've had very poor penetration into the healthcare marketplace because, again, of heavy regulation and the fact that they are very expensive to implement a new infrastructure for this. And then, obviously, economics plays a large role as well. As I alluded to, it's expensive to put this in place, but also insurance policies heavily dictated the reimbursement for telehealth, and previously telehealth was only reimbursed for patients in rural areas or in emergencies. As a result of this, telehealth was used by only 8% of Americans in 2019. Despite these barriers and issues with telehealth, many large healthcare systems had very slowly been investing in building up their digital space in anticipation of a time that telehealth would become more ubiquitous. And Medicare was a large part of this as well. In 2018, the Bipartisan Budget Act was passed that allowed Medicare Advantage plans to offer additional telehealth benefits as part of their government-funded basic benefits beginning in 2020. Up until this time, Medicare beneficiaries could only receive telehealth benefits if they lived in rural areas. And so these things were kind of trending towards telehealth, maybe becoming a little bit more used moving forward. And then the COVID pandemic happened, and which was the major catalyst that pushed telehealth to the forefront of medicine in a way that these previous years of technological innovation and advocacy could not. As our main kind of weapon against COVID has been social distancing and quarantine, there has been a large market for alternatives to in-person care. And this has forced medicine to reevaluate our current clinical practice. Many healthcare systems then had to very rapidly scale up their ability to perform telehealth. This was aided by the government. Very early on in the COVID pandemic in the US, the Department of Health and Human Services released a statement saying that during telehealth, covered healthcare providers will not be subjected to penalties for violations of HIPAA that occur in the good faith provision of telehealth during the COVID pandemic. And all services that a covered healthcare provider, in their best judgment, believes can be provided through telehealth in these circumstances are covered by this. Now, this meant that telehealth could be rapidly expanded because previously unavailable apps and devices that were not HIPAA compliant could now be used to perform visits with patients. This meant that popular apps such as FaceTime, WhatsApp, Zoom, Skype, that most of our patients already have access to, are able to be used with their physician for visits. Additionally, this relaxed limitations on which services could be eligible for telehealth, making telehealth much more feasible and easy to rapidly expand. With this, as COVID rose in the US, there was an increased interest in telehealth around the nation. So this graph depicts the Google search trends for telehealth and telemedicine in yellow and blue, which you can see very closely mirror the rise of COVID in the US, which is depicted in red. So as patients were more interested in staying at home and social distancing and quarantine, they were very interested in telehealth as an option to continue to communicate with their healthcare provider. So this telehealth transformation during COVID could be thought of as having about 3 different phases. And the first phase is depicted in blue here, which is stay-at-home outpatient care for typically chronic diseases or other things that can be managed as an outpatient. And this, as you can see, rapidly increased early on in the COVID pandemic, as I have mentioned previously, patients have wanted to stay at home. And then phase 2, which took a little longer to ramp up, is telehealth used on the inpatient side during the hospital surge. And then finally, phase 3, as depicted in the green line, is what is anticipated to occur during the post-pandemic recovery, where patients who were previously lost to care or deferred management of something or had an elective procedure or treatment deferred are now returning to care. And so it likely will cause or has caused a large patient surge that telehealth may be able to assist with. So during this time, healthcare systems have had to drastically change the way that they operate. And this example is outlined how the New York City Health and Hospitals system did just that. They are the largest safety net healthcare delivery system in the US, and more than 70% of their population is insured by Medicaid or has no insurance. So they're a population that is very vulnerable and at risk to being lost to care. First, they wanted to see if these patients were even ready or interested in virtual care. So they sent out a survey to all of their patients about their desire for telehealth, and they found that greater than 65% of their patients were interested in performing telehealth visits. They also found that greater than 75% of these patients owned a mobile phone, and that 60% of these patients used their phones only to access internet at home. So whatever telehealth system they designed needed to be mobile device compatible. Next, after gathering that initial data, they were able to implement a telehealth system using existing mobile health technology and focusing on rapid improvement. They kind of rolled this out very quickly and then had a telehealth rapid response team in place that was able to make day-to-day changes. And they had 3 goals with their telehealth system. And this kind of mirrors that graph I showed previously. First is to serve patients outside of the hospital, kind of with outpatient care. Second is to support patients and staff within the hospital. This is to decrease exposure to providers, to aid in ICU care, but also they used this to support patient-family communication and for palliative care for patients with COVID. And then finally, they also used this to monitor patients at home after discharge. And doing this, they were able to perform 83,000 billable telehealth visits in that first month of the COVID pandemic in New York, compared to a very, I don't know what the number was, but it was a very minuscule number prior to COVID. Similarly, this data was published by Duke in one of their outpatient provider clinics. And prior to the outbreak, they had performed less than 1%, or sorry, their total telehealth visits were less than 1% of their total visits, which is depicted, as you can see, in early February, kind of even going through mid-March. And then with the rise of COVID, beginning in late March to early April, they were rapidly able to increase their visits as well. As you can see here, they performed greater than 3,000 telephone visits per day and greater than 1,000 video visits per day. Again, this graph shows something kind of similar. This is provider organizations as broken into groups, depending on the number of clinicians in their organization. And this shows that, again, beginning in about early April, they were drastically able to ramp up their telehealth capacity. However, this extends the time out farther, and it shows that even beginning in late April, telehealth has already been declining pretty steadily. It has not yet reached our pre-pandemic levels, but there is a question, COVID is still around, why are providers now suddenly going away from telehealth? And there are a number of reasons for this. First is the issue of safety. We need to know that the provider on the other end of the telehealth call is qualified and competent. We need to know that the app that they're using or the technology that they're using is safe and has the accurate regulations in place. And finally, there has to be quality evaluation built into this process, similar to other types of patient care. Second is the issue of privacy. I talked before how prior to COVID, the privacy regulations surrounding telehealth were quite strict, and these were drastically relaxed during the COVID pandemic. Obviously, moving forward, then we will need to kind of figure out what is the right privacy regulations for COVID, or for telehealth, excuse me. And we'll have to figure out the right trade-off between privacy and ease of use of telehealth to continue appropriate use. Next is the issue of access. We need to know that patients are able to access this technology that we're using, and we also need to know that providers are incentivized to use it. And then last, of course, as affects everything, is payment. We need to figure out what the adequate reimbursement and payment structures are for telehealth, and we need to determine what new infrastructure needs to be set up and how much that will cost. So telehealth may be a way to provide more economic care. And the way that I see this and the best use moving forward is in relation to chronic disease. Currently in the US, there are greater than 100 million Americans with some sort of chronic disease. And this accounts for greater than 75% of our current healthcare expenditures. Telehealth can be used in this setting to help us decrease our healthcare expenditures, but also to cope with this ever increasing number of patients who need care for their chronic disease. As I mentioned in the beginning, telehealth does also improve patient outcomes. So I think this is a potential way to decrease our cost of care, increase patient access, while also improving their outcomes. And I think the best way that this can be used is transitioning our thought process and how we care for chronic disease from a traditional episodic office-based model to more of a care management model with frequent monitoring of patients. Obviously, this will require a lot of change in the way we practice and in infrastructure and all of that. But the way I see this is that patients will still need to come in regularly for physical exams and other things that cannot be performed over a virtual visit. However, in between those visits then, we could establish more regular telehealth visits with providers, with nurses, with dietitians, or whatever is necessary for their care, so that we have more frequent monitoring, we're able to adjust medications more closely, and that we're able to monitor how they're doing. So in summary, telehealth has been in existence for a very long time, and we know that it does improve outcomes and that patients are interested in using it. However, its mainstream adoption had been rather limited up until this point. The COVID pandemic was the catalyst that forced medicine to reevaluate our current clinical practice and led to a rapid increase in the use of telehealth. And then post-pandemic, I hope that we continue to use this resource that now most people are familiar with and incorporating it into the routine management of chronic disease. So with that, I would like to thank Dr. Chen, who helped me a lot with this talk, Dr. Fraser, Dr. Costco, Dr. Wren, the other APDs, and all my co-residents.
Okay, we'll now move on to the question and answer portion of Grand Rounds this morning. I can go ahead and start with my first question for Dr. Kannuthurai. You mentioned the increased cardiovascular risk, of course, of patients with RA throughout your talk. My question is specifically in relationship to their use of statins. So you discussed using that 1.5 factor to multiply the ASCVD risk score, but the data that you presented showing that patients with RA have similar risk to those with diabetes was particularly intriguing to me. What are your thoughts essentially on starting these patients on a moderate intensity statin just right off the bat as we would with any other patient with type 2 diabetes or diabetes?
So yeah, that's a good question. I think unfortunately a lot of the studies that we have on the hyperlipidemia in patients with RA, a lot of these are population-based studies, and so there haven't been a lot of clinical trials that have assessed this. But certainly, yeah, that was just like you mentioned with the ASCVD risk score. We automatically start patients with hyperlipidemia, with diabetes on a statin. And I think it makes sense for patients with RA, but again, there hasn't been any clinical trials that have really looked at that and tested that. But
okay, thank you. My next question for you is, did any of the studies that you looked at in patients with rheumatoid arthritis look specifically at lipoprotein A? Did you come across that in your preparations for this talk?
I did. There was I'm not sure if any certain particular studies looked specifically at lipoprotein A. I'm sure they have. I know Dr. Zicker is in the room and she probably knows a lot more about this than I do. But I think mostly what I had read about was the mechanism is fully understood, but just the fact that people with high inflammation and high inflammatory burden, they have this increased catabolism and clearance of LDL and other lipid components. But to be honest, how that affects ApoA, I'm not totally sure.
Okay, thank you. My next question is for Dr. Christensen here. So we have some questions here about the HHS waiver for HIPAA compliance regulations during COVID. Do we know any timeline about the extension of this for at least the next few years? Is this waiver set to expire, and will our current telehealth infrastructure, at least from what we've seen here, be dismantled or until it can be HIPAA compliant? Has there been any talk about this when you were doing your research for your talk?
When I was looking at this, they still have not said what their timeline is for this waiver. I think as everything with COVID, it's kind of dated as everything is changing so quickly. They aren't sure what's going to happen. So currently, I think we're still operating under this waiver. And as we move forward with COVID, I think they'll come out with more guidelines, but they haven't said anything about an endpoint yet. I'm guessing once they do, things will have to rapidly change with how providers are performing telehealth though. But hopefully they give us some warning with that.
Yeah, certainly. And then my last question for you, Dr. Christensen, in looking at the previous data that you encountered prior to the COVID pandemic, were there a lot of distinctions made between telehealth via video or via phone call? Because that's definitely one topic that's come up a lot as far as telehealth at our clinic at the Center of Outpatient Health.
In terms of the studies that I saw, I feel that they didn't really separate the data into phone versus video visits. It kind of depends on the institution and what they were able to set up, whether it was phone versus video. But pretty consistently across the board, I think both have shown to improvements in outcomes. I think just because of the frequency of monitoring, since it's so much easier for us to interact with our patients that way on a frequent basis, it's easier to stay on top of their care.
And then one more question based on our experiences at the Center of Outpatient Health. As a provider there, what have you seen that you feel like we can be doing more at our clinic to emphasize the use of telehealth with our patients, who can certainly derive a lot of benefit from the increased access to care?
I think one thing that I've seen in my personal experience, especially as relates to hypertension and diabetes, is that the telehealth allows us the ability to contact them more frequently without them having to come in. And as our patients a lot of times have to travel really far to get to our clinic or have to spend a lot of money to get to our clinic, I think that is a definite benefit for them. And it allows us to maybe talk to them every few weeks, like every 2 weeks or so, especially if we're titrating medications, as opposed to maybe every 6 weeks or 3 months when they otherwise would have come in, and you kind of miss a lot of time in terms of taking care of an uncontrolled disease process.
Okay, well, thank you both for your outstanding presentations today on two very different but very common topics that we see day to day in our outpatient care. If anyone has any other questions that are coming in, I can make sure that these get directed to our speakers as well. Thank you for joining us this morning. We'll continue our grand rounds next week.
You guys did a great job.
Thank you.
That was really wonderful. Thank you so much. So how are you? Good.